All right, let's dive right into this explainer. Today we're embarking on a pretty fascinating journey into polycystic kidney disease, or PKD. We are going to trace this condition all the way from the very first genetic spark that sets it in motion, right down to the cutting-edge disease-modifying therapies that are literally transforming patient care as we speak. If you've ever wondered how a tiny, microscopic genetic error can entirely hijack kidney function, and more importantly, how modern medicine is finally fighting back, you're in exactly the right place.
So here's our roadmap for today. We'll start with genetics and disease origins, then move to the cystogenesis cascade, followed by clinical impact and diagnosis. After that, we'll dive deep into the foundation of PKD management, explore tolvaptan and targeted therapies, and wrap up with advanced care and pipeline.
Okay, starting right off with Section 1, Genetics and Disease Origins.
Think about this for a second. 1 in 500. That is the staggering global prevalence of autosomal dominant PKD, or ADPKD. It's actually one of the most common monogenic diseases in the entire world, affecting an estimated 12.5 million people globally. It accounts for up to 10% of end-stage renal disease cases worldwide. But here's the crazy part. Despite how incredibly common it is, it still remains vastly underdiagnosed.
Now, we have to draw a stark distinction between the two main types of the disease here. On one side, we've got ADPKD, which is driven primarily by mutations in the PKD1 and PKD2 genes. Those PKD1 mutations make up nearly 80% of cases and unfortunately typically lead to a much more severe disease with an earlier onset of kidney failure. On the flip side, we have autosomal recessive PKD, or ARPKD. This one is way rarer, affecting about 1 in 20,000 births, and it's driven by PKHD1 mutations. It often presents in neonates with just massive kidneys and severe respiratory issues, and it carries a really high peritoneal mortality rate, meaning sadly shortly before or after birth. But while their genetics differ, both ultimately trigger a very similar destructive cascade in the kidneys.
Moving right along to Section 2, the cystogenesis cascade.
So how exactly does a genetic spelling error in these genes actually build a fluid-filled cyst? Well, it basically comes down to a three-step cellular hijack. Step 1 is polycystin loss. The PKD genes encode proteins called polycystins. You can think of the polycystin complex as a vital cellular brake that relies on calcium signaling. When a mutation breaks this complex, intracellular calcium drops. Step 2, without that calcium brake, a chemical messenger called CAMP just floods the system. And step 3, this massive accumulation of CAMP acts as a bright green light for the mTOR and MAPK pathways, which are essentially our cellular growth engines. The end result? Unchecked cell division and relentless fluid secretion right into the tubule, ballooning it out into a cyst.
Let's bring this to the patient level with Section 3, clinical impact and diagnosis.
What does all this microscopic chaos actually look like for the patient? Well, early hypertension is a massive red flag. It actually affects over 70% of patients and often pops up way before we see any detectable decline in kidney function. Why does that happen? Because as those cysts expand, they literally compress the blood vessels inside the kidney. This tricks the kidney into thinking it has low blood pressure, which fires up the whole renin-angiotensin system. Patients also frequently deal with flank pain just from the sheer physical mass of the kidneys, and they can have episodes of gross hematuria, which is blood in the urine. But here is absolutely a crucial takeaway for you. There's an 8 to 12% risk of intracranial aneurysms. So a sudden thunderclap headache in an ADPKD patient, we have to treat that as a ruptured aneurysm until proven otherwise.
When it comes to confirming the diagnosis, especially when there is a family history, we rely on the Unified Ravine criteria. It's essentially an ultrasound-based numbers game. It's not just about spotting a random cyst. It's a strict, age-adjusted set of thresholds. For instance, if you're between 15 and 39 years old, finding just 3 cysts across both kidneys is enough to lock in that diagnosis. But as you get older, that threshold goes up, simply because simple, harmless renal cysts become a lot more common in the general population anyway. Now, while ultrasound is great for diagnosing the disease, MRI is the absolute gold standard for staging it. We measure what's called the height-adjusted total kidney volume, or HTKV. If a patient's HTKV is sitting over 600 milliliters per meter at any age, that is a glaring, blinking red signal for a high risk of rapid disease progression. This exact measurement feeds straight into the Mayo Imaging classification, which is what helps doctors predict how fast the kidneys will fail and figure out who desperately needs aggressive treatment.
All right, pivoting to solutions in Section 4, Foundation of PKD Management. Modern PKD management starts with some surprisingly simple but frankly profoundly effective conservative strategies to slow that cyst growth down as early as possible. First off, we advise patients to drink 3 or more liters of water a day. And this isn't just about general hydration. Massive fluid intake essentially acts like a drug here. It chronically suppresses vasopressin. Remember that CMP chemical messenger flood we just talked about? Well, vasopressin is the main driver of intrarenal CMP. So by suppressing vasopressin with all that water, you actively keep the pathogenic CMP level down. We also strictly limit sodium to under 2 grams a day to quiet down that renin-angiotensin system we mentioned. We restrict caffeine because caffeine actually prevents the breakdown of CMP, keeping it dangerously high. And finally, we heavily emphasize regular, moderate exercise to help manage that critical blood pressure element without putting too much strain on the kidneys.
Building right on top of those lifestyle changes, we absolutely have to lock down that early hypertension. This treatment strategy is completely anchored in the landmark HALT PKD trial. What this trial proved is that for young patients in the early stages of the disease, rigorous intensive blood pressure control, meaning we are targeting under 110/75, actively slows down the overall growth of total kidney volume. Our first-line agents for this, ACE inhibitors or ARBs, these are standard, highly effective blood pressure meds that directly target that inappropriately activated renin-angiotensin system.
Which brings us to a major breakthrough in Section 5, tolvaptan and targeted therapies. Enter tolvaptan. Right now, this is the only FDA-approved disease-modifying therapy we have for rapidly progressive ADPKD.
So what is it?
Tolvaptan is a selective V2 vasopressin receptor antagonist. Basically, it acts as a highly specific artificial brake. It sits right there on the exact receptor that vasopressin usually binds to, and it completely blocks the signal. This essentially shuts off the factory that's producing that flood of CMP, which in turn halts the whole process of fluid secretion and cellular proliferation that blows up those cysts in the first place. The data backing this up? Absolute massive milestones in nephrology. In the Tempo 3-4 trial, which looked at early-stage disease, tolvaptan nearly halved the annual growth rate of kidney volume compared to a placebo. That's huge. Later on, the Reprise trial showed that it also significantly slowed the decline of actual kidney function, the eGFR, even in patients with later-stage disease. Now, it's not without side effects. It does cause intense aqueresis, meaning patients pee a whole lot, sometimes up to 9 liters a day. And more importantly, because there's a real risk of liver toxicity, patients have to be enrolled in a strict mandatory safety program called REMS. This requires monthly liver enzyme blood tests for the first 18 months, just to be absolutely sure they're safe. Finally, let's look to the future and ultimate interventions in Section 6, advanced care and pipeline. Now, if ADPKD does progress to end-stage renal disease, renal replacement therapy becomes the necessary next step. The good news is patients generally tolerate both hemodialysis and peritoneal dialysis really well. But the ultimate salvage therapy here is transplantation, ideally preemptive, meaning getting it done before dialysis is even needed. And here's a deeply reassuring fact to keep in mind. Because ADPKD is a genetic defect that's native to the patient's own kidneys, the disease literally cannot recur in the new transplanted kidney. As a result of that, the 5-year graft survival rate for ADPKD patients exceeds 85%, which is exceptionally good. Of course, the ultimate goal is to avoid transplant entirely, right? And the emerging drug pipeline for PKD is incredibly exciting. Because the pathobiology involves so many multiple parallel pathways, researchers are now developing drugs to block completely different parts of the cyst-building machinery. For example, vengislutat is an oral drug currently in phase 3 trials that targets the biosynthesis of lipids that modulate cyst growth. Then you have CFTR inhibitors in early phases, and they're aiming to physically block the chloride channel that actually pumps the fluid into the cysts. And bardoxolone is being investigated to activate antioxidant and mitochondrial pathways to try and preserve overall kidney function. Which actually leaves us with a pretty provocative thought. Right now, tolvaptan is our single heavy hitter. But preclinical models are showing massive synergistic benefits when we combine therapies that target completely different pathways at the exact same time. So as we look ahead at these upcoming multi-target combination therapies, are we finally entering the era where end-stage renal disease from polycystic kidney disease is entirely preventable? The science says we're getting closer every single day, leaving immense room for hope for millions of people worldwide.